Thank you very much. Obviously, we'll introduce the topic of interstitial lung disease. Some disclosure before starting. Been receiving the grants for making presentations, but haven't received for this specific presentation. I will introduce you the topic of interstitial lung disease and the concept of lung fibrosis. We'll discuss briefly about how we do make a diagnosis of interstitial lung disease, some insights in idiopathic pulmonary fibrosis and on the concept of progressive interstitial lung disease, fibrosis. And I will also briefly mention some hot topics in the field of interstitial lung disease. I will not have the time to discuss any aspect of therapeutic trials. So let's start with the introduction to interstitial lung diseases and lung fibrosis. So interstitial lung diseases encompass a group of conditions which are considered rare and involve the lung parenchyma and interstitium of the lung. It's considered rare because it's present in about 60 to 80 people every 100,000 people that live in a country. And in UAE, this means about 8,000 people have this condition. It is classified according to etiology. Mainly, we have two groups. The one is the group of the idiopathic interstitial pneumonias. Obviously, it means that we have little clues about the origin of the conditions. There is a large group related to autoimmune disorders, and there are other two major groups. One is the hypersensitivity pneumonitis due to the exposure of organic dust and the granulomatous disease called sarcoidosis. So the concept of fibrosis is important because it is associated with reversible, often progressive destruction of the structure of the lung. And this can occur because of different reasons, as there are different etiology, but is often unpredictable in its rate of progression. And it leads at the end to their respiratory failure, requiring the patient oxygenation and eventually lung transplant. I will mention now briefly about the main condition, how we do mainly diagnose their interstitial lung disease. Obviously, patients come with very simple and common symptoms, especially exercise-induced breathlessness and cough. But also we detect patients because incidental finding on their CT scan, radiological, or on a restrictive pattern on pulmonary function testing. And also we screen patients we know they have a high risk of developing interstitial lung disease, like the group of patients with rheumatological conditions. Obviously, there are also rare patients with family history of interstitial lung disease, and in which case also it will be easy for us to screen for ILD. There are simple clinical signs that are anyway very important to look for. So the finger clapping is easy, lost because if you don't look at the fingers of your patient, but it's very important, indicates a chronic respiratory condition. And also there are vertical sounds which are very typical. And I invite everybody to listen to the lung because it's very characteristic, the sound. Mainly comes at the lung basis. So it's very important once we are suspecting interstitial lung disease, we use a proper in-depth history because exposure to dust and organic dust particularly is very critical in differentiating the idiopathic conditions from hypersensitivity and pneumonitis. But also it's very important to consider screening for autoimmune condition, which is the other large group of interstitial lung diseases. But obviously, the key element for diagnosis is the high-resolution CT scan of the lung. This should recognize what are the most relevant patterns, which are fine reticulation, ground glass pattern, opacities, mosaicism, traction bronchiectasis, and honeycombing. Obviously, this pattern should be addressed in their spatial of the lung, so distribution of the pathology is also very important. For example, this is a case I've recently seen with polymyositis, dermatomyositis, a young patient with no respiratory symptoms. And you can see here in the yellow arrow that there is very minimal changes that might have been missed in a quick review of the CT scan. also associated with very borderline restrictive pattern. These findings has changed their treatment for this gentleman, as we know that this is likely to progress to something more important. In this case, also we asked for the expiratory phase, where we can see there is some mosaic perfusion mosaicism, for example, in these areas here. And this is important because sometimes those mild features can be enhanced by a technique that is the expiratory phase of the CT scan. Briefly about idiopathic pulmonary fibrosis, which is the most important pathology because of this severe prognosis and the need to distinguish it from other interstitial lung diseases because of different therapeutic approach. So idiopathic pulmonary fibrosis is chronic, progressive. We don't know the real cause, although some insights are now available. It's mainly for the condition of the elderly, and the prognosis is very poor, worse than most cancers. The symptoms are extremely common. We are talking about, again, shortness of breath on exertion and cough. So many doctors think first to their asthma, COPD, or an infection of the respiratory system. But this leads to a delay in the diagnosis. So it's very important when we are dealing with chronic symptoms to consider to do further investigations. I said that there are new highlights, and I want to, in the pathogenesis of idiopathic pulmonary fibrosis, I want to bring to your attention that there is evidence that an accelerated senescence of their cells of the lung is part of their pathway for the pathogenesis of this disease. When we're talking about IPF, we are considering, sorry, I apologize, the usual interstitial pneumonia, which is not the same as saying idiopathic pulmonary fibrosis, because it's a common pattern to other conditions as well. But it's very characteristic if it's in the patient with the characteristic I was mentioning you before. And you can see here there is subpleural reticulations in the first two images. And here we can see some honeycomb, which is prevalent in the lower part of the lungs. So, and is very characteristic of the usual interstitial pneumonia. I want to introduce to you also the concept of progressive fibrosis, because this is very important for the future in changing treatment in the group of conditions with autoimmune disorders. This is to show that fibrosis is quite frequent in many of the interstitial lung diseases. About 1/3 of patients can develop fibrosis, although it's not for all interstitial lung diseases, but only some of them have this feature. If you have the feature of fibrosis, your loss of function is similar to that of idiopathic pulmonary fibrosis, hence also the mortality changes significantly. I will briefly mention about some hot topics in this field and some news. For example, now we have new guidelines on treatment for sarcoidosis, just released a few weeks ago by the European Respiratory Society, with a clear pathway on how to use the steroids, immunosuppressants, biologics. This is the fibrosis we can see in sarcoidosis. Although sarcoidosis is multiform, and the type of fibrosis we can see can vary quite a lot significantly. There are also new guidelines how we detect their hypersensitivity pneumonitis. Essentially, they try to conjugate their high-resolution CT scan pattern with the evidence of inflammation in the bronchial alveolar lavage, mainly lymphocytes. And this has been reported by the guidelines of the American Chest Physician, as well as the American Thoracic Society and Japanese Society as well. This is very important. We discuss the cases of interstitial lung disease usually in a multidisciplinary team meeting, and having a certain degree of confidence is important to take decision. This is, for example, a case of hypersensitivity pneumonitis I've seen, and there is a gentleman who has a respiratory failure on walking and when he flies. If you do a normal CT scan, unless you know what you're looking for, you don't find anything. It looks like a normal. But if you pay more attention, in the blue arrow, I highlighted some of the area of the lung where there is an increased density. And with the yellow arrows, I highlight some of the areas where there is less density. It's like what we call the 3-density pattern. It's very minimal. Many doctors might miss it. I'm not saying it's very evident in this case, but this is what is a typical case we face. And now look at what happens if we do an expiratory phase of the CT scan. This becomes clearly evident. There is diffuse mosaicism with loss of blood in certain area, and it's very clear that this is a pathological lung. There are also new guidelines released from the Fleischner Radiology Society about the effect of the newer anti-neoplastic medications, which are continuously used, and they put in relation with their clinical presentation and CT patterns. For example, in the acute phase, we can have an acute interstitial pneumonia, which is associated usually with diffuse alveolar damage, or transient pneumonias, which migrate also in the lung, is associated with simple eosinophilic pneumonia. There are also subacute and chronic condition, which is organizing pneumonia and non-specific interstitial pneumonitis. This is a case, for example, of lung adenocarcinoma, and you can see here there are areas of consolidation highlighted by the black arrows. Those areas were there, but they were weaning after a few weeks, and then at some point disappeared by themselves. These are areas of eosinophilic pneumonia. While in this case, for example, of adenocarcinoma, we have a larger consolidation with some ground glass, which is typical appearance of organizing pneumonia. Overall, it's very important the temporal correlation between the appearance of the interstitial lung disease and the administration of the drug, obviously. And there is important to exclude other causes of interstitial lung disease. This has, unfortunately, to lead to the drug discontinuation and sometimes also to use the immunosuppression treatment in patients with cancer. There are other now getting more and more popular newer medications in the cancer field, that is, for example, the anti-HERB2 drug conjugates, which have a significant efficacy, especially for example, we have more evidence for breast cancer. But we are now using it more in other type of solid cancers. And there are also these, they can cause interstitial lung disease in up to 15% of the patients, and 3% have a fatal interstitial lung disease. Overall, I'll give you the last news we have is together the Emirati Thoracic Society and the Rheumatology Emirati Society are going to publish very soon a consensus statement on the treatment and management of systemic sclerosis interstitial lung disease. And for whoever of you is interested in the field, there are two events coming in the next few days. One is on the 23rd of October. It's about the interstitial lung disease organized by our society. And the other one is about the relation between the autoimmune conditions and the interstitial lung diseases. Thank you very much for your attention.
Thank you very much, Professor Facchini.